Other people have several guidelines, but I don't know if there is any evidence-based guidelines for the treatment of epilepsy in Africa. I don't know if Charles knows. I don't. I don't think there is. Then we have to find one. What could then be if there is no evidence-based guidelines for the treatment of epilepsy? What could we then do? My suggestion is that we just take the evidence that is available elsewhere and apply it in the meantime to our situation, adapt it, while waiting that we will get our evidence ourselves and build our own guidelines that rest on our evidence, local evidence. And these are the questions that we can ask that would go into what dress code we need to put on to be able to fight our hidden enemy. Why do we have to do medical treatment? It's already been done. Whom do we treat? Who prescribes? When do we start? What do we use? How do we proceed? What about the costs and the health systems? When do we stop? Those are some of the questions. Yes, we need to treat people with epilepsy with anti-epileptic drugs because we know that about 70% of these people will get seizure freedom if they have optimum anti-epileptic therapy. We also know that more than 70 to 80% of the people who have this disease in Africa do not have access. The treatment gap, we've been reminded in the morning, is high. In some places it is not known, but it is estimated that it is very high. Whom do we treat? Only people with epilepsy, because the treatment takes long, the side effects are not insignificant. So if we treat people who do not have epilepsy with anti-epileptic drugs, which are not always there, it will be a waste and it will be dangerous. So people with epilepsy only. That raises the issue of case ascertainment. We need to know exactly the seizure type per individual and classify these seizure types into the syndrome depending on the clinical evidence and paraclinical evidence that is not always there, but we need to make an effort to have it there. In the treatment-naive patient, we have the issue of the single seizure. It might be the first and the only seizure. I think that the evidence shows that it is reasonable to start treatment if there is evidence that this single seizure is happening in a context that we are sure that seizures will repeat themselves. If there is a structural lesion or if the syndrome is so clear from clinical and electrophysiological investigations that this is a condition that will repeat itself, then we can start. But if not, then we can wait. If we look and we see that there are precipitating factors, there are circumstance-linked seizures, then we need to wait and not start treatment. And if we have a situation where adherence to treatment would be difficult, for example, we have someone who is chronically addicted to alcohol, and we know that in any case, there will be issues with being adherent to the treatment, we might need to consider to wait until we solve those first problems. Then with a chronically ill patient, we know that 80% of patients are controlled with monotherapy for the chronically ill patient. And if we cannot control the seizures, about 15% of the patients would need a second drug to be controlled. But if it goes more than 2, we need to be careful, as we already were reminded this morning. The more the drugs, the more expensive, the more dangerous, and we don't know what we're doing. Another thing that we need to take note of is that when we see patients that may be referred to us as chronic epilepsy, we need to revise. We always need to check again, because not all that have been considered chronic epilepsy patients are really chronic patients, because in several series, 10 to 15% of these people, when they are evaluated very well clinically and otherwise, are non-epileptic attacks. And we know that if we have the opportunity to look carefully, we can find an etiology in up to about half of the patients with chronic epilepsy. What do we use? We have already discussed this. We have heard many people talk on this morning. 3 situations. Well, when you want to wear something, you wear what is available. So we use what is available, and we have the established anti-epileptic drugs. Even out of the established anti-epileptic drugs, we know that not all are easily available on our continent, so we use what we have. And our friend Pro this morning, in response to the question on phenobarbital, said, well, if you don't have good water to drink, you drink the water that you have. The second group is that we may use what may be available, the new ones, the series of new anti-epileptic drugs. What to remember is that they give a little more comfort. In other words, the side effects are less, but generally they're equally effective as the old ones. And more importantly, they are more expensive, extremely more expensive for most of our patients. So that may be available. We're not sure. The third situation I want to discuss or throw to you for discussion is that we could think in the future of using what could be available. And in that, I'm suggesting that we need to look very seriously. I know there's going to be a session on this tomorrow, African traditional medicine and the African pharmacopoeia. There is some wealth that is untapped, and I think it is for us to look at that and make it available when that time will come. We know that it takes a lot of time for drug development, but we may have to choose different paradigms to arrive at how to use this wealth that we have and we are not using. This is not a good slide, but it's there just to illustrate. This is a list of existing anti-epileptic drugs and pharmacokinetics. We can get this from any reference. And the next slide, it's not a good slide either. It gives suggestions on dosages. But again, this is information we can get from textbooks or papers. Again, the idea is to start with one drug and start with small doses. So start with one drug, start with small doses, and then increase them until you have efficacy, or you stop when the side effects are not tolerable anymore. And as much as possible, avoid using 2 or more when you don't have to, because that already complicates the relationship between the drugs and the relationship between the drug and the patient and many other things, as you always know. Another issue to think of is cost effectiveness. And that is why, for most cases, phenobarbital will continue to have a place in our context, and then other cheaper drugs will continue to have a place. But you have to look at the clinical situation and look at the indication. Consider issues of tolerability, because we're talking about dress codes. This is very fanciful. It's beautiful. It's great. African fabric. But it will be very difficult to move with this on the street. I mentioned traditional healers. They have a role to play, and traditional medicine certainly has a role to play. It is for us to define in what conditions and to bring out the evidence. We had the opportunity to do a survey with traditional healers, and we were surprised that these guys think 75% of them think that epilepsy is treatable, and 95% of them would like to collaborate with us Western physicians. This was a surprise to us, and I would like to encourage our colleagues to look at that. Who is to prescribe and follow up? The physician only? I don't think so. I know some people in this hall may think that only the super specialist, the epileptologist, should prescribe. But I would suggest that the physician, not the physician only, even nurse practitioners, if they are well trained, they could be allowed to do prescription under supervision. But the roles have to be defined clearly, and capacity building and policy and legal issues have to be sorted out in each country. We made this suggestion that non-physician management of epilepsy in resource-limited contexts is not only possible, but a need in Africa. Some of the guides that can be used to train nurses, examples are available. Nurses have a role to play. What type of follow-up? Certainly clinical follow-up is important. Electrophysiological follow-up is important. Imaging may not be possible. Where it is possible, fine. Drug monitoring should be considered. It is not a must, but when it is available, it does help in some situations. And finally, who pays for the care? I know that many of us do not even know what the cost is because this has not been calculated in many of our countries. And our situations do not allow us for these costs to be shared. But we neurologists, we the caregivers have to provide the leadership. Most of the financing of epilepsy is out of pocket in Africa. But as you can see in many other countries, there are schemes and systems that make the sharing of costs. What should we remember from what I have said? Simply, that optimal anti-epileptic drug management of people with epilepsy in Africa is not just possible, it is mandatory. It is, in my opinion, an issue of a human right for the people with epilepsy. I don't like to look at the challenges. I see the challenges rather like opportunities to build capacity, to do more research, research that will inform policy, and policy that will improve the quality of life for people with epilepsy. Thank you very much.